Good day, guys. In this video, we'll study about endometriosis and adenomyosis. This is Dr. Rahul SM here. I will guide you through the whole topic. So, starting with the definition of endometriosis, it's a common benign chronic disease in women of all reproductive age, right? So, it's a common benign chronic disease in women of all reproductive age. So, endometriosis is caused because of the occurrence of endometrial tissue outside the uterus. So, the age of onset is between 20 to 40 years, and this is often asymptomatic. So, this is often found incidentally. And next is the etiology or the causes of endometriosis. So, speaking about the etiology, the retrograde menstruation causes endometriosis. So, retrograde menstruation, this theory is proposed by Sampson's implantation theory, where the endometrium goes out through the holes. The endometrium goes out through the tubes. So that is called as the retrograde, the backflow of the bleeding. So the endometrium implants on ovary, ligaments, and bowel. So it's said that over 70 to 80% of all women with reproductive age, they have retrograde menses. So what are the other causes of endometriosis? Coelomic neoplasia, iatrogenic implantation, and dissemination of endometrial cells. There are various other causes as well. So, speaking about the risk factors, nulliparity, prolonged exposure to endogenous estrogen. Endogenous estrogen is nothing but the estrogen which is produced inside the body. So, in case of early menarche, the patients or the females are exposed to lots of estrogen, and even in the late menopause as well, they are exposed to a lot of endogenous estrogen that can cause endometriosis, and short menstrual cycles as well. That implies when the menstrual cycle is less than 27 days, and menorrhagia greater than 1 week can cause endometriosis, and the family history as well, right? So next we'll study about the pathophysiology of endometriosis. So speaking about the pathophysiology, so as we discussed already, it's due to the endometrial tissue that occurs outside the uterus. And there are some common locations where the endometriosis is usually presented. We'll speak about the possible pelvic organs. So, ovaries, which is the most common location, and it's usually bilateral. And the rectouterine pouch, fallopian tubes, bladder, and cervix, and also in the peritoneal cavity, and in extra pelvic organs as well. So speaking about the extra pelvic organs, there are lung, nose, eyes. So when the endometrial tissue grows in the lungs, this causes periodic hemoptysis, and in the nose it causes periodic epistaxis, and in the eyes it causes periodic subconjunctival hemorrhage. So this is called as vicarious menstruation. Because regardless of location, the endometrial tissue which grows outside the uterus mimics the same as the original endometrium. So it undergoes all the hormonal cycles and usual menstruation. So that causes bleeding. So as a result of which, it results in the increased production of inflammatory and pain mediators. Nerve dysfunction and anatomical changes, and finally it causes infertility. So next, we'll study about the clinical features. So the patient presents with chronic pain and acute monthly exacerbation because of severe congestive dysmenorrhea, and it also causes deep dyspareunia. Dyspareunia is pain during sexual intercourse, and the patient has menorrhagia and infertility as well, right? So we'll speak about some of the clinical features. In uterus, it causes uterosacral tenderness and nodularity. In ovaries, it causes lateral pelvic pain and back pain. So the uterus and the ovarian clinical features are the most common, and if the endometrial tissue grows in the urinary tract, so it causes dysuria, cyclic hematuria, and suprapubic tenderness or pain. Because of which the patient has recurrent urinary tract infections and urinary incontinence. So next we'll study the pathology of endometriosis. So coming to the pathology of endometriosis, I'll show you the clinical presentation of endometriosis. So this is the classical feature of endometriosis, where the endometrial tissue grows outside the ovary. So the pathology is powder burn lesions. You can find powder burn lesions or blue spots on the serosal surface of the ovaries and peritoneum. So this is the powder burn lesion or the blue spots which is seen on the serosal surface of ovaries and peritoneum. And in ovary it causes the chocolate cyst. So this is the typical presentation of chocolate cyst of ovary. And it also causes scarring and adhesions in fallopian tube. So you have blue spots or powder burn lesions, chocolate cyst of ovary. The chocolate cyst of ovary is due to the endometrial shed in the ovary, and it cannot move outside. So it's the collections, it keeps collecting and it forms a cyst and it presents like a chocolate, and it's called as the chocolate cyst. And you also have scarring and adhesions in fallopian tubes as well. So this has a higher risk of ectopic pregnancy and that results in decreased transmittance. Now we'll study about the possible diagnostic procedures to diagnose endometriosis. So coming to the diagnostic procedures, so you can use the marker CA125. There will be increased level of CA125 in the blood, but this is not a gold standard marker because CA125 can be seen in all cancers as well. So in order to confirm, you do ultrasound and MRI, and you use transvaginal ultrasound and laparoscopy. And also the physical examination is more important, and the physical exam shows rectovaginal tenderness, adnexal masses, and lateral displacement of cervix. This lateral displacement of cervix is due to the uterosacral scarring. However, the severity of the findings, they don't correlate with the severity of the symptoms, right? So next, we'll study about the treatment of endometriosis. So speaking about the treatment, the first line treatment is surgery. Surgery is the first line treatment. You can do adhesiolysis in case of adhesions. You do cystectomy for the chocolate cyst of ovary, and you do ablation for the deposits and the fulguration of deposits. And there is a chance of 60 to 70% recurrence even after surgery. And other options could be hysterectomy, removal of uterus. And then comes the medical management. So in medical management, you can give the hormonal therapy such as progesterone. So that causes the atrophy of endometrium within 3 to 4 months of treatment. And you can also give combined oral contraceptive pills for anovulatory cycles, and this limits endometriosis. And you can also give GnRH analogs. And the other factors could also be pregnancy. So when the female is pregnant, that limits endometriosis. And then we'll study about, this is all about endometriosis, and then we'll study about the adenomyosis. Adenomyosis is nothing but, it's more or less same like endometriosis, but it is a condition where the endometrial tissue grows in the myometrium, right? As we know, the uterus has 3 layers: perineum, myometrium, and endometrium. So adenomyosis is a case where the endometrium grows into the myometrium of the uterus. So this is a typical picture presentation of adenomyosis. Alright, so speaking about adenomyosis, this is usually seen in multiparous women over 40 years of age, and also 30% of So 30% of hysterectomy specimens. So this is, as I told you, this is a benign disease which is characterized by the occurrence of endometrial tissue within myometrium. So this is due to the hyperplasia of endometrial basal layer, and also due to disruption of myometrial border, the endometrial myometrial border, due to multiple pregnancies. So this adenomyosis is also called as endometriosis interna, because endometriosis occurring inside or within the myometrium. So now, speaking about the etiology or the causes of adenomyosis, so it's associated with menorrhagia and progressive dysmenorrhea, and obviously endometriosis, uterine fibroids, and parity. So these are the most common causes of endometriosis interna or adenomyosis. So coming to the clinical features, they may be asymptomatic, so you have dysmenorrhea and you have the abdominal uterine bleeding. It causes chronic pelvic pain aggravated during menses. And speaking about the uterus, in this case, the uterus is globular and uniformly enlarged. And it attains less than 14 weeks size of the pregnant uterus. So usually pregnant uterus within less than 48 weeks or 14 weeks, so it is around 14 centimeters. So in case of adenomyosis, the uterus size would be 14 centimeters. So speaking about the diagnostic procedures in adenomyosis, we can do transvaginal ultrasound and MRI for further evaluations. So coming to diagnosis, you have transvaginal ultrasound, MRI, and in MRI you can find myometrial cyst because there is growth of endometrial tissue within myometrium, so you can find myometrial cyst in MRI. So usually, speaking about the junctional zone between endo and myometrium, the normal size is around 5 to 8 millimeters, but in adenomyosis it's greater than 12 millimeters, and that gives us the diagnosis of adenomyosis. And also you can do uterine biopsy, right? And finally coming to the treatment of adenomyosis, for menorrhagia you can give hormone therapy and the NSAIDs such as ibuprofen, mefenamic acid, naproxen for pain. In young women, you give hormones and combined oral contraceptive pills for longer duration, and IUCDs with progesterone. And the overall best treatment would be hysterectomy. So I hope you guys are clear with endometriosis and adenomyosis. I'll give you a heads up on the next video. Thank you for watching.